Dear students, you are welcome to our topic 1. You may recall that last week we talked about the overview of health policy, of which basically we touched base on the key concepts, of which we had an opportunity to define what is policy, what is health policy, the importance of health policy, and these are the aspects that we covered in our last session. Now today, as part of the topic 1, we're going to talk about the typologies of health policy. And I'll focus on 4 typologies of health policy, of which I'm going to talk about politics policy as one of the typologies of health policy. The second one is law politics policies. And 3 is about distributive policy. And the 4th one is regulatory policy. As we go along, I would like you to keep Tanzania in mind and ask yourself the following question. Where have I seen this in our health system? I understand that some of you are working within the health sector, or you have an idea of how the Tanzanian health sector or health system works. So as we go along through these typologies of health policies, try to keep in your mind about this important question. Where have I seen this in our health system? Now, let's start by the I politics policy. These are the big P. We call these are the big P because it is called I politics policies, or of which the political decision in the health. It focuses on the political decision in health, which attract the attention of the president, the cabinet, the parliament, and the ambassadors. I want to be clear that when we're talking about high politics policies, they basically attract the attention of the president as the head of state. They attract the attention of the cabinet, and they attract the attention of the parliament and the ambassadors. Why? It's because they touch on big money, they touch on the core ideology of the country, they touch on, and sometimes they touch on the international relations. So think of the decision, okay? Think of the decision like the introduction of the major health financing reform, or a big shift in how we pay for providers. Of course, in Tanzania, you know, a very good illustration is debated. Is about the debate and the introduction of pay for performance. It's very commonly known as P4P. Okay, you know, this was not just a technical idea. For those who knows about P4P, this was not just a technical idea from the health economists. Okay, that we're talking about pay for performance that is coming from health economics. No, it was just strongly pushed by high-level development partners, and of course, it was taken up by the political leaders. Why? Why? The question could be why it was taken by the political leaders. It is because it promised visible results. You know, ideally, they thought that we will pay for results and automatically it's going to improve the performance. That was an assumption that if we pay someone to produce a specific results, automatically these individuals are going to improve their performance. But in that processes, there were some tensions between what some technical staff, for example, in the ministry thought was feasible and what the political actors and donor wanted to see. So this tension between the technical staff within the ministry who thought that was visible, but also on the side of the political actors and donors about what they want to see. So that is a classic high politics. It's a classic high politics in the sense that it requires a lot of negotiation. Negotiation among who? Among those parties. Among, for example, the the technical team, the political actors, the donors. So it requires a lot of negotiation because each of these actors have or has a specific interest. They have the specific interest. They have the specific influence. But also is classic because it requires a lot of bargaining and more often cause a lot of pressure, in that particular process. For us to understand high politics policies, we can cite another example in the process of developing, for example, the health sector strategic plans. You may all understand, or you are very much aware that in this country we have health sector strategic plan 1, and currently we have health sector strategic plan 5. It means there has been a process of developing this health sector strategic plan, health sector strategic plan 1, health sector strategic plan 2, health sector strategic plan 4, and the current one, health sector strategic plan 5. In the course of developing the health sector strategic plan, it's important to note that these are not just the routine planning documents. It's not just a routine planning document, but they normally define the overall direction of the health sector. They normally define the overall direction of the health sector. They normally define the key priority areas of the health sector. But also, they normally provide a direction in terms of how large amount of money from the government and the partners will be spent. So they have to go to high-level forums. Okay, they have to go to high-level forum so that they can be discussed. They can be discussed with top-level development partners, and usually they embody choices. Okay, they embody different choices with regard to equity, for example. They discuss about the role of the private sector. They discuss about the decentralization processes and even issues related to universal health coverage. So those choices, okay, those choices are inherently political. You need to remember this. Those choices are inherently political. Why? Because they usually tell us what kind of health system we want as a country. What kind of health system we want as a country. So, in a nutshell, we can say that high politics policies, these are visible. These are visible. They are visible because you can see who are the key actors, who are contesting, who are discussing, who are bargaining, who are arguing in terms of what should be considered as a priority for the health sector. But also, these are usually contested and they are symbolically important. So, these are the ones that can win, or these are the people who can win or lose the election. For example, on the side of the government, that we have the health sector strategic plan because we have an election manifesto. We have several promises that we have given to the public, to the population, to the country. So we need these promises to be part and parcel of the health sector strategic plan. So, and sometimes because of this kind of contest, you may find even sometimes they can even affect the relationship with the donor. So in most cases, the high politics policies are not left to technocrats alone. They involve all powerful actors in the cause of formulating even the implementation of these policies. The second one, as you can see in the slide, is law politics policy. These are still policies, okay? These are still policies, despite the fact that they are called policies, but these are still policies because they matter a lot. But they are more technical, okay? Despite the fact that we are saying these are law politics policies, we should note that these are still policies, they matter a lot, but they are more technical and they are less visible. And so, sometimes they are less controversial. They are less controversial because these decisions are often delegated to departments. Okay, as we have said, as I have said, that these are more technical. It means the decision of the designing these policies, uh, implementing these policies. Okay, they are left or are delegated to departments, to technical working groups, for example, even to the district teams. And we are going to see a typical example in Tanzania, how the law politics policies maybe are translated from the politics policies. Let us take an example. uh, Once the health sector strategic plan, for example, has set the strategic direction. We have the strategic plan, and it has set the strategic direction. It means that there must be someone who has to translate those strategic direction into detailed planning and the budgeting guidelines, for example, at the council level. And that's why you may note that, for example, if you look at the format of the CCHP, we call it Comprehensive Council Health Plans, or the planning template, the detailed steps on how the CHMT should plan and the reports. These are usually treated as the technical matters, okay? Are technical matters because they involve health planners at the council level. For example, the health information health management information system officers at the council level, even the program coordinators, more than the ministers and the MPs at the council level, because these are what we call low level politics. And we can think about another example, maybe related to regular updating of the clinical guideline. When the experts, for example, update the malaria treatment protocol, or maternal and newborn care guideline, at whatever level, for example, they normally use the evidence, for example, from WHO, or even from the local studies, or even use the context specific program data. Unless there is something very sensitive, for example, like introduction of new vaccine, which can become a high politics, most of these guidelines updates remain low politics. Why? Because they do not make newspaper headlines, but they strongly influence what happens at the level of facilities. So, low politics policies, in most cases, they tend to answer this specific question, that how, for example, how and in detail do we implement what has already been decided at the higher level? As I said, in most cases, the high level politics, so the low level politics, these are more for technical, and they are less visible, and they are usually less controversial, because at this level, the main issue is to ensure that the law politics answer the question, how do we implement what has been already decided at the higher level. As I said, they normally they normally become high politics, for example, if stakeholders with the power decide to politicize the law politics. But in a day-to-day practice, they are treated as a technical issue. And looking at the third typology, sorry, which is distributive policy, sometimes it's called the allocative policies. Distributive policy, from the word distribution, is sometimes they are referred as allocative policies. Here the key idea is distribution of resource. Okay, is a distribution of resources. That is a key idea behind the distributive policies. And the main question that we need to ask ourselves when we are talking about distributive policies is, the main question could be, who gets what, where, okay, and in what quantity. So, so the political message is often about what are we bringing, what are we bringing services or resources to the people. That is the main question. What kind of services do we want to bring to people? What kind of resources do we want to bring to people? Rather than, for example, asking ourselves, what are we taking something away from others? So the question is, who gets what, where, and in what quantity? We can take an example. We can take an example in the Tanzanian sector. In the Tanzanian health sector, for example, the health basket fund. We can use it as a typical example that government and the partners in most cases, or usually, they tend to pool resources and then use these funds allocated to councils to do what? To implement agreed priorities, especially those priorities under the health sector strategic plans. So we can say that in the from the typology perspective, this is distributive. You know, this is distributive. Why? Because we are taking a pooled resources, we are taking a pooled resources, we are taking a pooled money and distribute it across LGAs. Why? Because we want to support services. And in that process, in most cases, you know, every council, for example, you may find that every council wants a bigger share, okay, wants a bigger share from the pooled resources, of course, but politically it is framed as supporting all districts to implement the national strategy. As you know, that the resources are always scarce, and the health needs are very high because of different factors. You know, the rising of infectious disease, non-communicable disease, the increased population. All these are pushing towards high healthcare needs. So when it comes to the government to decide where to distribute the resources, so it doesn't mean that resources can be distributed equally for each district or for each facility. No, but there are issues that should be taken into account. So we can say that another distributive example is investment in the primary health facilities. This is an example that I was talking about. For example, if you want to focus on the distributive example in the investment in the primary health facility, where you can think about the construction of health facilities, or you can think about the rehabilitation or upgrading of dispensaries, health centers, and district hospitals. That is when you may find the government, for example, has to use the distributive health policies to make sure that the distribution of either resources allocated to council to implement the agreed needs or the agreed priorities are considered in a way that each council, for example, or each facility gets what is supposed to get. But there are several criteria that has to be taken into account. Now, try to think about, for example, when the government is planning or is launching, for example, the program to build theaters or maternity wards or laboratory in many districts. That is distributive policy. Just an idea or an action of the government to launch a program to build the theaters, okay? And this has been taking place across the country, or to build maternity wards or laboratories in many districts. That is distributive policy, because it may use various formulas. For example, that favors even the underserved regions. But the narrative, the most important narrative is, are we expanding, okay? Are we expanding the access to quality healthcare across the country? That could be the main question. Are we expanding access to quality care across the country? We're not talking about equality, but we're talking about equitable distribution. That's why when we talk about distribution of resources as part of the distributive health policy, there must be some of the key formula, there should be some of the criteria that can guide the distribution of these bigger resources available. So we can also think about the distribution in terms of human resource. You may recall that when we are studying Pub 762, the human resource for management, human resource for health management in our first semester. You remember that we talked a lot about the distribution of human resource in this country, talking about the shortage of human resource for health in particular in underserved area or in hard to reach areas. So we can think of the distribution in terms of human resources, whereby the policies, for example, that deploy new graduates to priority districts or even provide hardship allowances to remote areas are distributive, because by using such policies, it means uh, there is a possibility of allocating staff and incentive to places that previously had too few health workers. Okay, and again, some districts, they may feel, okay, or some of the district may feel that they got less, but they got less few human resources. But the overall framing is that the state is trying to correct that imbalances. Okay, that despite the fact that some of the facilities, also some of the district may get fewer resources, but through this distributive health policies, the aim and the overall aim is to ensure that the state or the country is trying to correct that particular imbalances. So for those of you who are working, no, who are studying health economics and financing, those who are pursuing Master of Health Systems in economics and financing, you should know that distributive policies raise interesting questions, and based on this question, perhaps you can get some of the topics that you can use to write your dissertation. Distributive policies raises interesting questions, and one of the questions could be, are these allocations efficient? Are these allocations efficient? That's one. But second question that you can ask yourself, are they equitable? Okay, are they equitable? The distribution of resources, is it efficient? But is it equitable? But also you can ask the third question, who actually benefit most from the basket fund, for example? Who benefit most from the basket fund? Who benefit most from the new facilities that are being constructed? Who benefits more on human resource for health who are deployed? And how can we measure that benefit empirically? Is it possible? So these are the questions that you can ask yourselves. The last one is regulatory policies. These are about rules. Okay, these are about rules. As you can see, as they are being defined, regulatory policies, it means they are focused on rules and regulation. So these are about rules, of which the main questions that are asked under the regulatory policies could be, who can do what, under what conditions, and what happens if they do not follow the rules. These are the questions that can be asked when we are talking about the regulatory policies. And basically, the aim of the regulatory policies is to protect the patients. Is to protect the patients, is to ensure that there is safety, is to ensure that the services provided are of high quality, and sometimes they aim to protect the financial stability of the system. That's why we talk about regulatory policies, because the main focus is to make sure that we are protecting the patients. We are protecting the patients by ensuring that the services that are provided are safe and of high quality, but also is to protect the financial sustainability of the system. In Tanzania, for example, the recognition and the regulation of the private and the faith-based providers could be used just as a strong evidence or a strong example on how the regulatory health policy works. Some of you might recall, for example, starting from 1990s, 1990s, 1990, 1991, 1992, okay, from 1990s onwards, you may recall that the policy and the law started to formally be recognized, to recognize private for profit, and even the FBO policies. Okay, because why the question could be, why at that particular time from 1990s that policies and law started to formally recognize private for profit and FBO facilities? Because why? Because in that particular recognition, the aim, that recognition came with licensing requirements. It's not just a matter of recognizing, okay, we have the private for-profit facilities, or we have FBOs. No, the recognition was tied up with licensing requirements, was tied up with quality standards, was tied up with the reporting obligations and the supervision arrangement. That even if you are the private for profit or your FBO, you need to meet the licensing requirements. Okay, you need to meet the quality standards, but the reporting obligation and the supervision arrangement. When I talk about the reporting obligation and supervision arrangement, what does it mean? Maybe for just a simple example, you cannot be a DMO in a particular council where you have private and public facilities and even the FBO related facilities that are providing services in that particular service, and say, no, our focus is on the public health facility. No, it is a requirement and a responsibility to make sure that even whether these are private for profit or whether these are FBOs related facilities, they must make sure that they provide services that meet the quality standards, but they are supposed to meet the reporting obligation, and even the supervision arrangement can be extended to these facilities. Why? Because they are contributing to provision of health services that aim at improving the health outcome of the population. Another example of the regulatory health policies, we can look at an example using the service agreement, for example, and the public-private partnership framework that exists in this country. The service agreement and the public-private partnership framework basically do not only focus on giving money and support. Okay, this service arrangement and the PPP framework, they are not just focusing on giving money and support to make this kind of arrangement work. No, they even set some of the key conditions. For example, what kind of services must be provided in that particular service agreement or in that particular PPP framework. What kind of services must be provided? What kind of standards must be met? And even what data must be reported? Okay, so it doesn't just look on okay, that we are going to give the support in terms of money. No, but also focus on what services that should be provided, what standards that should be met, but also what kind of data that should be reported. So we can say this, for example, this PPP arrangement, it mixes distributive elements with the regulatory ones. Okay, so you find there is a mixture of distributive arrangement and regulatory sanction, regulatory ones. So let's look at another example of the professional. For example, when you look at the professional councils, okay, we have the professional councils, but the professional councils, these are the regulatory, okay? These are also the regulatory instrument. Looking at, for example, the medical council, or the nursing and midwifery council, or the farmers council, and the others. And currently, I've seen that even the health secretaries, the Association of Health Secretaries in Tanzania, they are moving towards establishing their own council. But why? Why are we talking that, or why are we discussing that professional council are also the regulatory instrument that falls under the regulatory health policies? Is because even these professional councils, they normally determine who is allowed to practice. For example, if you go to the medical council, they determine who is allowed to practice and under what conditions. And what happens, for example, if there is a case of multi-practice uh, among the members, So through the licensure, registration, and even disciplinary procedure, they regulate the behavior of health professionals to safeguard the public. So this is a typical example of the regulatory policies. So on the service side, for example, the essential health benefits package, it has been increasingly used as a regulatory reference. The essential health benefit package, is increasingly being used as a regulatory reference. Why? Because it is not just only a list of services, but it is embedded into the facility standards and the planning tools. Why? Because these facilities are expected to provide that package at their level and the supervision. But data reviews and the performance assessment check whether they actually do what they are expected to do. So, as Tanzania moves towards universal health coverage and a more strategic purchasing, many of these regulatory elements are becoming stronger. Okay, Tanzania is moving towards universal health coverage, and undoubtedly, more strategic purchasing, particularly many of these regulatory elements, will and are becoming stronger in terms of accreditation of the contracting, in terms of data quality requirements, and even performance. So this is important. Now, so to summarize, between what we have discussed, it's important to note that when we are talking about high politics policies, it's important for you to think about big reforms and the big money that are always contested at the highest political levels. I think you may remember I said when I talk about high politics policies, those key big actors, the government, okay, as a state, even the development partners, they are contesting to make sure that key major reforms either could be financing reforms or sector-wide strategies. Each of these actors are interested to make sure that their interests, okay, are taken into account. And then for law politics policies, it's important as a take-home message to think and to remember that law politics policies these are technical. The technical implementation details are used, for example, in the planning format, in guideline updates, and development, and ensuring that the supervision tools are used. And the third one is distributive policy, of which you may remember we said it's important for us to ask ourselves key important questions with regard to who gets what, whether it's basket fund allocation, who gets what, if it's about facility construction program, who gets what and why, if it's about HRH deployment schemes, who should get how many health workers of this specific profession and why. And the last one is the regulatory policy, of which it's important to think that rules of the game are at the center of the regulatory policy, such as issues related, for example, issues related to licensing, issues related to facility standards, issues related to regulation of public-private partnership, even rules of the game regulating conditions related to performance payment. So when we analyze the Tanzanian health policy, it's important for us to remember that we have these key important typologies of health policies that that can be used to guide the policy formulation processes, the policy implementation processes. But maybe the question could be, between of these four typologies, which is more interesting on your side, or which are out of these four is mostly you have an experience with. You may recall when we started this session, I said it's important for you to keep in mind and ask yourself, where have I seen this in our health system? So take this question, think about it, and perhaps we can have a discussion in our online session about where have you seen either of the four within our Tanzania health system, and what kind of experience do you have with regard to this. So let me end up here. That marks the end of our first topic. In the coming session, we're going to talk about the second topic. Otherwise, thank you so much for your time.